Next, assess the cardiac aspects of the thorax. Help the patient into semi-Fowler's position and move to the right side of the table. Check his apical pulse. Inspect the 4th and 5th intercostal spaces at the mid-clavicular line. To help visualize the pulse better, you can repeat the process with the patient on his left side. Remember, in about half of patients, the apical pulse isn't visible. Palpate the apical pulse even if it's not visible. It should feel like a short, gentle tap and should be palpable in an area about 1 centimeter by 2 centimeters. Using the ball of your hand, systematically palpate the heart's borders in the sternoclavicular area, aortic area, pulmonic area, and left ventricular area. Note any lifts, heaves, or vibrations. Now auscultate for heart sounds with the patient in 3 positions: lying on his back with the head of the bed raised 30 to 45 degrees, sitting up, and lying on his left side. Auscultate the heart at the right second intercostal space close to the sternum, along the left sternal border in each intercostal space from the 2nd through the 5th intercostal spaces, and at the apex. As you auscultate using both the diaphragm and the bell of the stethoscope, determine the patient's heart rate and rhythm, and listen for the normal heart sounds, S1 and S2. S2 is best heard at the base of the heart and corresponds to pulmonic and aortic valve closure at the end of ventricular systole. S1 is best heard at the apex. It corresponds to mitral and tricuspid valve closure at the start of ventricular systole. It should coincide with the carotid pulse. Especially note the timing of heart sounds in relation to the cardiac cycle, and stay alert for abnormal heart sounds, such as S3 or ventricular gallop, which may be a cardinal sign of heart failure, and S4 or summation gallop. S4 results from vibrations caused by forceful ejection of blood from the atria into ventricles that expand less than they should.